All right. All right, I think I can get started. Welcome to my webinar, and ANA's webinar. My name is Tara Crockett. I am the Director of Clinical Quality at Fresenius Kidney Care. I am going to present on promoting standards for safe workplaces. I've been in quality and performance improvement for about 10 years. Did a little bit of simulation. I was a certified healthcare simulation educator. Familiar with team steps, lean methodology, a little smattering of everything. But currently I am purely quality and patient safety. So today we're going to talk about quality benchmarks in the acute setting. So at the end of the presentation, I am hoping you will all be able to summarize the purpose of quality assessment and performance improvement for hospitalized dialysis patients, explain the 6 quality domains for healthcare, use a quality collaborative model to develop an acute dialysis quality program, develop potential acute dialysis quality measures, and relate importance of a culture of safety and overall patient outcomes. So essentially, quality is the management of variation in outcomes. The challenge is that organizations profess patient safety and quality as a top priority, but they're still figuring out how to manage it with the same rigor, discipline, and accountability that they do their budgets. And Peter Pronovost said that, and I can't say that this is more true than our current healthcare climate. So if you're familiar with quality improvement, you may have heard of W. Edwards Deming. His pioneering work in the second half of the last century formed the foundation of how we do QAI. Deming believed that quality improvement is everyone's responsibility. He taught that meeting patient and customer needs without variation takes leadership, systems thinking, constancy of purpose, and joy in daily work life. Donovidian was another pioneer who brought QI concepts and methods to healthcare. If you've ever heard that outcomes are the result of structure and process, you know of his work. Structural measures are how we organize care. So for example, the ratio of providers to patients. So the ratio of dialysis nurses or PCTs to patients in a suite. Process measures are actions taken. So generally they're guided by evidence-based guidelines. An example would be time to TPA. An outcome measure is the result of our care. So for example, the rate of surgical complications or hospital-acquired infections. Shortly before Donovidian's death in 2000, he gave an interview to a leading healthcare policy publication. The interviewer asked him, "Why do we do quality improvement?" And he said, "Ultimately, the secret of quality is love. If you have love, you can work backward to monitor and improve the system." So why do we do QAI? As clinicians and healthcare leaders, we have love for our patients, our professions, and each other. Love is why we're working in dialysis, even when less challenging fields are available, and it gets us through tough days, and we've had some really tough days lately. So let's talk about how to create a quality improvement and assessment program for hospitalized dialysis patients. So the Armstrong Institute model of quality work framework includes 5 components and 4 work streams: patient safety, external reporting, patient experience, value, and equity. During the rest of the presentation, we'll talk about the 4 work streams that are necessary to effectively and efficiently develop quality programs that encompass these 5 components in order to improve overall patient outcomes. In March of 2017, I started at my company as a senior director of quality for our inpatient services, and it was a new role. Shortly thereafter, our quality team rolled out some quality initiatives utilizing the Quality Collaborative Model, or QCM. The QCM is based on the Armstrong Institute model and is built on a framework that recognizes that a large organization can coordinate quality improvement efforts across organizational levels via 4 work streams. These work streams include defining and communicating goals and measures, creating and enabling infrastructure, engaging frontline clinicians, and creating clinical communities to support peer and organizational learning, and establish transparent reporting and ensure accountability. So the foundation of the QCM consists of operations, quality partnerships, and work streams replicating across organizational levels. Through this partnership, an infrastructure is formed that enables identification and management of variation. We've seen that a couple of times already. Convening teams to problem solve together. And lastly, transparent reporting and accountability. Step 1, defining and communicating goals and measures. So as I mentioned, my role at the company was a new one. And before my role, there was not really a formalized quality program. I was pretty local. I was starting from scratch, essentially. I was also new to the company, so I also had to learn where I fit in the company and who could assist me getting our quality program rolling. So I had to start at the beginning, and I began with meet and greets and started introducing myself, my role, and quality concepts to the operations team. Operations consists of frontline staff, managers, directors, vice presidents, and C-suite. I attended operational summits with directors of operations, attended leadership meetings, and met with medical directors. I wanted to build relationships and develop thinking partners. As we all know, results happen at the speed of relationships. I also wanted to understand the current state. I found that although everyone felt that quality was important, they didn't totally understand how it fit into daily work or how to report it in an efficient and, more importantly, effective way. I elicited invitations to weekly and monthly operational calls to provide quality updates and keep quality top of mind. I started simply with basic reviews of QAI and then added quality-focused topics such as dialysis orders, scope of practice, etc. Created a quality gap analysis, quality overview report, and quality presentation for our C-suite. It was important to start communicating quality expectations. What were the goals? What were the measures? How are we going to monitor quality? We all know you can't improve what you can't measure. So step 2 in the QCM is to create an enabling infrastructure, and this is where the real work really began. I held various Skype meetings and in-person quality and QAI trainings with our operations and technical teams. We enhanced our treatment record in order to capture the quality and patient safety data we needed in order to track performance and identify opportunities for improvement. We worked with education and operations to create a tiered quality training. So those were both in-person and mandatory LMS for our managers and frontline staff. And then lastly, we created quality metrics and standardized reports and developed an electronic quality dashboard so that everyone could easily track quality and patient safety. So our quality measures encompass the 6 domains of healthcare quality. So according to the IHI quality framework, the 6 system level domains of quality include safety, timeliness, effectiveness, efficiency, equitable care, and patient-centered care. And you can remember that with the acronym STEEP. And that all contributes to the patient's experience of care. So let's take a moment to talk about these 6 domains. If you can find your chat button, I would like you to write in the chat what you think the definition of safe care might be. And I'll give you just a little bit of time here to start clicking away, and then we'll discuss it, which means me reading your answers and giving you the formal definition. Let's see if anybody can try get their chat going here. What do you think safe care might be? According to policy, yeah. There's more than that. Let's see. Provide care while doing no harm. I would have to say ding, ding, ding. because that one, avoiding harm to patients from the care that is intended to help them. Ethical, adhering to standards, patients not getting hurt. Exactly. So we want them to come out of the hospital healthier than they went in. We don't want to give them any associated infections or any other kind of harm while they're in the hospital. Good patient outcomes without any injury. That's awesome. So how about timely care? What do you think the definition of timely care might be? Give you a minute to think about it. Why might timely care be important? The tough one. Care when it's needed. Exactly. So let's say that we have a patient, address the problem ASAP. So let's say that we have a patient who is in the ICU and all of a sudden they need CRRT. Timely care is reducing waits and sometimes harmful delays for both those who receive and those who give care. Care done as patient condition warrants, giving treatments when needed, especially with emergencies, absolutely. So we want to make sure that we can provide or get a patient on CRT as fast as possible, because that is going to prevent further harm from helping them. So from harming them. So those are some great answers. I will review the next couple. So effective care is providing services based on scientific knowledge to all who can benefit and refrain from providing services to those not likely to benefit. So this addresses underuse, misuse, respectively, really trying to think of what is the best care for that patient. Efficiency is avoiding waste, and this is where lean came from. Including waste of equipment, supplies, ideas, and energy. So this is waste of, I love the fact that they include energy. So what can we do to make our systems leaner so that our nurses don't have to run around the place, right? So really thinking about that critically when you're thinking about processes and measures. Equitable care is providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. And this has really been in the forefront lately with the COVID vaccinations and getting people vaccinated in low-income places. And how can we, think about providing healthcare in a way that meets everyone's needs? And then lastly, you've all heard a lot about patient-centered care in the last few years. Put in the chat what you think the definition of patient-centered care is. And I'll give you a minute. What does the patient want done? Collaboration between caregivers and family and patients, care that revolves around the patient's specific needs. Patient has input, and you guys are nailing this one. Patient first, include family, customized care, absolutely. So the official definition, providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So again, this is all around HCAHPS. I think that's why everybody is so on top of this one. So that's great. Thanks for participating in that one. So before we proceed and talk more about quality measures and specific ones, let's talk about what makes a good measure. So what is a performance measure? It is a quantitative measure that provides information on critical aspects of activities, such as the effect on patients during a given time period. These measures can then be compared to the target goals set by the organization. So you want to make sure that you're always measuring something at baseline before you implement an improvement project. So performance measures are based on data and tell a story about whether an organization or an activity is achieving its goals and objectives and how much progress is being made toward reaching those goals. It's very important. Performance measures or quality indicators mean the same thing. So why do we need to measure performance? Well, we need to establish a baseline and identify areas for improvement so we can set improvement goals and measure our progress towards those goals. We can't just go about and implement something without knowing what its impact is going to be. We want to evaluate how well we're doing. We need to inform first-line providers, clinical teams, hospital management, leadership, and patients on what to expect from our services or treatments. And we would love to allow performance comparison across sites. We need to set industry standards. And then we'd also do these for accreditation purposes. So a good measure, when you are creating a measure, you ask yourself these 6 important things. Is my measure relevant? If it's not, no need to measure it. Is it meaningful, right? Is it controllable? Do you have ultimate control? Now, if you are creating dialysis specific measures, there's a lot of other people who have control over that patient most of the time. So you have to be very cognizant. Is what you're doing ultimately, going to be able to be measured? Are you going to have impact and the only impact on that measure? Is it important to enhance health? Otherwise, why do it? If there's no room for improvement, there's no point in measuring it. Is it evidence-based? So that's scientifically sound. And is it feasible? Sometimes we try to measure something that's almost impossible. It takes too many people, too much time, too much money, that sort of thing. So these are 6 really good questions to ask yourself before you create any quality measure. So now we'll look at some possible quality indicators that could be used to monitor inpatient dialysis, clinical quality, and patient safety. These measures can be structural, process, or outcome measures. We will use polling to select measures that address some of the 6 domains of quality. So as a reminder, an outcome measure measures the end results of care, and a process measure measures the actions taken. So we're going to try this. We're going to open a poll. This will be our first question. So select the measure that best fits into an example of a safety measure. I'll give you a little bit of time to do this. Maybe 30 more seconds. Gotta find my timer. Okay, well, I'd love to see the answers. Let's see what people picked. 88% said timeout. That is awesome. I'll close that poll. So measuring compliance to a timeout procedure before the start of a dialysis treatment is an example of a safety metric. Because remember, safety metric is avoiding harm to patients from the care that's intended to help them. So making sure, right, double checking, we have the correct site, the correct procedure, we have the correct patient is very important. And this actually has become a national patient safety goal and has trickled across procedures from it used to be just solely a surgical procedure checklist. And now, it's before dialysis because it's an invasive procedure. So what are some other examples of a safety metric that you can think of that you might want to implement for dialysis quality and patient safety? Go ahead and write a few suggestions in the chat. UF rate, HDV monitoring, BMM, patient ID, Hep B, double check on electrolytes in the bath, hospital-acquired infections, orders, dialysate bath orders. Absolutely, right? So if we're thinking about avoiding harm, what are the things that we should be checking, especially the actions that we're taking, right? So definitely consent. I see that. Hand hygiene. That would be part of an audit. We do audits. Those are considered safety. Lab values to correlate with orders. PPE compliance. You guys are getting it. There's a lot of safety metrics we could definitely look at. Checking access, right? So again, this is a process metric. We're looking at the actions that were taken and are they according to guidelines. So if there's something very specific you want to measure because it's correlated with good patient outcomes and it avoids harm, that is a safety metric. All water and dialysate testing. Awesome. Awesome, guys. Great. All right, let's open our second poll. So we're going to select the measure that best measures that best fit into an example of a timeliness efficiency measure. And I am going to give you 45 seconds. Actually, I'm going to give you 30 because you guys were really quick last time. All right, 10-second countdown. All right, let's close that poll and let's look at the answers. All right, so we have 52% say pre-treatment report, 61 say delays, and 27 say stats. And we have a smattering of pain. So now I'll show you the answer. The measuring percentage of delayed treatments is an example of a timeliness measure. Remember, that's to avoid harmful delays and reducing waits. And that's really closely tied to efficiency, which would be a stat, an example of a stat, or a process, sorry, I'm getting mixed up. Stats would be an example of an efficiency metric because we want to look for any waste, right? They tie very closely because if we are doing something that's wasteful, that can negatively affect wait time for other folks, right? So if we measure stats, we could see if there seem to be a lot of unnecessary stats, which would be wasteful. We pay more money for that. We pay potentially overtime for our staff. It could be long days for our staff. It could cause a harmful delay for somebody else who's waiting for their treatment. So thinking about that carefully, right? So we're trying to reduce waits and harmful delays, and we're trying to avoid waste. So those are two really good examples of timeliness and efficiency metrics. Let's open our third poll. We're going to select the measure that best fits into an example of an effectiveness measure. And again, I'm going to give you 30 seconds. All right, 5 seconds. All right, let's close that poll and take a look. All right, so we have 48% says complete orders, 6% says percent of transplant, 13 says patient ID verified, and we have 32% saying timely assessment. So let's look at the actual answer. So measuring percentage of patients on a transplant list is an example of an effectiveness measure. Since we know that transplant is the best way to improve a patient's overall health outcome. So similar to that is offering PD first instead of going straight to placing a line and performing hemodialysis. So remember, effectiveness is providing services based on scientific knowledge to all who could benefit, and refraining from providing services to those who are not likely to benefit, right? So we could think of some other examples of this, and I'm going to have you write some potential examples of effective care in the chat, thinking about that definition. And I'll give you about a minute. What could be an example of effective care? Think about evidence-based care. Meeting UF goal. Meeting goal. KT over V. So some of that, right? So effective care and outcomes can get mixed up a little bit. No potential for CLABSI, awesome. Repeat lab results, decreased oxygen needs, anemia stats. So when we're thinking around this treating hypotension, all of those are good. I want you to think more around, for this one, did we provide treatment options to a patient, right? So when they came in, did we urge them to do, did we show them that PD might be the best opportunity for them before placing a line? Did we talk about home therapy with them? For those of you that have CritLine to use, did we use CritLine? That's the most evidence-based way of removing fluid in the acute setting, right? Did we try to get a line out and get a fistula graft in sooner? So that would be effective care, and really also keeping in mind, the patient's needs. Number of patients choosing home, absolutely. So this is a toughie, right? Effective care. So let's go to the last one here. We're going to open our last poll. Select the measures that best fit into a patient-centered outcome measure. Remember, outcome measures are end result of care. And then again, 30 seconds. All right, 5 more seconds. All right, let's close this poll, see what we came up with. All right, so we have patient satisfaction, 81%. And then we have patient grievances, 31%. That's awesome. So I'll show you the answer. So measuring patient satisfaction or patient grievances are examples of patient-centered care. So remember that providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that their patient values guide all clinical decisions. So if we think about outcomes, that's where this patient satisfaction comes from, and the inverse of that would be patient grievances. So if we are being respectful and responsive, our patients are going to be satisfied. And this is a huge, weighed very heavily for hospitals as far as reimbursement. So listening to our patients, being prompt, addressing any grievances really goes a long way. So those are a few things that you can consider when creating your own quality indicators. So let's move now to tracking data. So step 3 in this framework is developing capacity using CQI, education, and clinical communities. So this is important because clinical communities support peer and organizational learning. So earlier I mentioned we rolled out quality indicators, electronic dashboards, and standardized reports. We needed to ensure that all operational staff knew how to use the tools and understood their rationale. We scheduled separate quarterly operational technical quality calls, as well as 2 clinical community calls to review all the new tools and expectations. And once all the new tools were up and running, we included regulatory partners on our calls, because we work very closely together. And it was important for the frontline staff and managers to see cause and effect. So why do we have this quality measure? Well, it ties to this regulatory standard and vice versa. Understanding why we do things is very important for our frontline staff. So topics also included creation of a culture of safety, patient safety event policies and procedures, joint commission citations, letting people know what people are looking for, what's important, scope of practice reviews, QAI importance and meeting requirements, as well as quality summary reporting. I mentioned earlier that we formalized operational quality trainings and held people accountable to advancing through the tiers. So we have 3 tiers of quality training, and ideally all 3 should be completed in 1 year's time. Well, that's a little bit delayed at the moment, right? Everybody knows how COVID has impacted staffing all around. And so things like this tend to take a little bit longer while we're having staffing crises. So the most beneficial enabling structure was the creation of our internal electronic quality indicator dashboard. It's a one-stop shop for all things quality. There's indicators, audits, meetings, and reports. So quality indicator data is automatically gathered for the managers and displayed on a dashboard. Action plans can be started right from this dashboard and tracked in the platform as well. So building capacity is incredibly important. Quality work cannot be done in a vacuum. It takes a team. So it's important to convey that quality work is something we do with clinicians, not to them. So we must engage frontline clinicians and create clinical communities to support peer and organizational learning. This can be done in a multitude of ways. And these are just a few examples. You can have quality and regulatory, clinical, and technical calls with your folks. Group emails work well. A lot of you have Teams or Zoom or IMs. Staff huddles, either in person or over these platforms, these virtual platforms. Having your own SharePoint page. QAI landing pages, newsletters. On the left is an example of one of the newsletters that our interdisciplinary team gets together and writes important quality, regulatory, education, policy, procedure information in, and send out to our frontline staff. So the last step in our journey is to establish transparent reporting and ensure accountability in order to manage variation. We revised our quality assessment and performance improvement policy and procedure to clearly state our quality expectations, which included how frequently data should be reviewed and reported out at meetings. Importantly, we used our electronic quality platform to create higher level dashboards so that all local data could be rolled up to regional and enterprise level to identify system level opportunities and for accountability purposes. We created high-level quality dashboards and reports for clinical and technical quality data and audits, QAI requirement completion, and patient safety event reporting. To promote patient safety reporting, we enhanced our patient safety policy and embraced a just culture, including just culture language in our policy and training. And we provided this to all frontline staff. We gave them information on best just culture practices. So let's talk a little bit more about promoting just culture because it is key to transparent reporting and accountability. So a just culture is how an organization behaves when no one is watching. The culture of an organization greatly influences the safety of daily operations and the overall effectiveness of quality improvement. I always liken this to how my teenage son behaves when I'm away for the weekend. So is he going to listen to my rules? Is he going to, pretend like I'm there? Or is he going to have a party and everything breaks loose, right? Fostering a culture of safety assists you in identifying areas for improvement and promotes staff engagement in improvement efforts. So in order to ensure that frontline staff and leadership embrace our quality requirements, every year we incentivize a different piece of our quality program. So for those of you who are familiar with Cotter's model for change framework, the fifth step is to empower others to act, and so incentivization. So this includes communicating metric goals and progress towards achievement, engaging frontline staff to identify root causes of low performing metrics and determining actions that can lead to improvement, providing transparent, actionable data that allows for trending, benchmarking, and visibility to quality at local, regional, and national levels. So the data that's obtained will ultimately be used to guide system-wide performance improvement strategies. Incentives can include awards or recognition, clinical ladder progression, or it can be monetary. So a couple of final thoughts before I open it up to Q&A. Everyone in your hospital has a role to play in the development of a company-wide culture of safety. Very important. Ask yourself, what do you need to do today to influence quality and support embracing a culture of quality improvement? And that concludes my presentation, and I would love to take any questions, comments. We have some time. I'll look at the chat. There's a QA icon you can click on and then enter them there or type them in the chat as well. Okay. Yep, there could be chat or there can be Q&A, either place. Okay, I have a question. In the chat, how many of you all work in hospitals and you are tasked with creating the quality program or reporting on quality? If you do, if you have that type of role, write it in the chat. And what are you currently doing to monitor quality? You do have a shy group. Work in the hospital, only worked on timeliness of care, do audits. Right, timeliness of care is very important. Once I have to report to hospital quality committee. We also participate in a Peak of Excellence project yearly for the hospital. I love that title, Peak of Excellence. Can you talk a little bit more about Peak of Excellence? What kind of projects are you guys doing? Someone says we track URRs and adjust treatments to get adequate URR greater than 65% for all patients. Someone says, due to COVID for the past 18 months and now with staffing shortages, our unit-based shared governance hasn't been able to meet. Yes, this has been a very trying time for quality. So I've been solo working on clinical issues as well as the quality piece. I heard an interesting piece of data on another webinar where it said that this past year has put us back 10 years as far as our quality improvement. All of the things that we've made progress on in 10 years has declined because of the COVID. Okay, question. Can you speak to conflicts that arise out of productivity versus quality? For instance, some safety steps could get skipped in favor of starting the next treatment. Yeah. This is where that culture of safety really comes in. So the first thing that you would have to do if you see these type of things starting to happen is look at the culture. And so really, we want to be efficient, right? We really want to get patients in. We have a lot of productive challenges, right? So we want to make sure that we are constantly communicating with the staff that safety is important, and that if they see anything, they need to say something. So it's really, if you see something, say something, and then we need to do something about it. So really that going back to the basics and talking about what is a just culture, and having people feel safe in reporting things that are happening out there, and then we have to address it. And if we can't address something right away, as leaders, we need to go back in and follow up with those folks and say, I hear what you're saying. I know this is important. We will do something, this is what we're doing about it. We may not be able to address this particular piece right now, but we will. And so we want to make sure, again, just culture. And if you're seeing things sometimes that people are doing workarounds and that sort of thing, just because of production issues, we have to go back and just talk about taking a few minutes here could save a lot of time later. Someone said that they have a quality role. They chart compliance with documentation, pre and post handoff report, consents, Hep B, looking at CLABSIs, machine disinfection. All of those are really great things, and that, they're all around patient safety, and very, and regulatory, looks at this very closely. So great. She said she also developed an emergency operation plan for post-COVID critical staffing fallout. And transportation turnaround, right? So a lot of times delays are caused by transport. And if we can bring that data to the hospital, they could, in fact, try to give us an extra transporter during peak times. It might be cheaper than some of these delays that are happening. COVID transporters are quitting their jobs because of COVID, and nurses and everyone is overworked. But yeah, it's a rough time, guys. We just got to hang in there and really try to remember about the joy, right? It ties back to that joy, and why are we dialysis nurses, and why do we do our jobs? And really, when we are rolling out things, making the time to celebrate small wins. So in this time of strife, when we're overworked and high stressed, setting small little goals and celebrating it really helps with our staff morale, and helps also to foster that culture of safety. This year we did a Bon Appetit, a team approach to bone health. Oh, I love that name too. That's awesome. Nurse manager, acute hemo monitoring. She monitors water testing, CLABSI rate, staffing, new on and off kits. Any tips for getting through surveys when they're looking at quality metrics like the Joint Commission? Any tips for getting through surveys? I think always being survey ready, right? So if we're constantly looking at our quality, and that goes back to quality is daily work and everyone's job, not just someone's job. So having a just culture when you walk into your suite or your bedside treatment room and you see things that are dirty or you see things that are ripped, you have to say something. If you see something's broken, you have to say something. Sometimes we get used to things and we don't think it can be addressed. So always having an eye towards defects and reporting those. Always having an eye on our quality metrics, not staying, not leaving it for 3 months before we get a chance to look at it. If we're addressing things as they're happening, that helps us with our surveys. If they do find something that is not quite up to snuff, if we've already identified it, then we are going to do a lot better in a survey than if they find it and we've done nothing about it. So someone, Jean just said that Glenda Payne and Jean published Acute Dialysis Survey Readiness Handbook. It's available at the AAMI bookstore. There's a little plug. More questions. Hang on, let me see if there's any more questions here. So some additional things that quality research creative ways to hire staff and not wait for Indeed, and created Q&I, Joint Commission dialysis related questions and environment, IC related topics that supervisors quiz staff on a regular basis. Absolutely. That is definitely part of quality's job, is to make sure that we know what surveyors are looking for and helping our staff be survey ready, knowing the answers, knowing the policies. Auditing is a great way, guys, to make sure that our staff know how the policies and procedures. Don't hold on to those yourself, right? Don't be the audit police. Share those audits. Have your nurses do audits on themselves. It reinforces the policies and procedures and helps them be comfortable with the questions that Joint Commission will ask. They need to make sure that they all answer things the same way, right? So if they're auditing with standard audits and they know what's expected of them, it will help them be survey ready. And ultimately, if we're following policy and procedure, our patients are going to be safe. So it's a win-win situation. I think that is all of our questions. And thank you, those of you that asked and contributed. Any other questions before we proceed? Wow, that's a big picture. I gave my information. If you feel more comfortable reaching out and asking via email, I'm totally on board with that. So my information and my cell phone is there. If you have any additional questions, I'm happy to answer them.